Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
What does it mean to feel safe in your own body, especially after trauma or injury? I'm Dr. Jessica Schwartz, physical therapist, concussion educator, and brain injury survivor. And today on the Concussion Corner Podcast, I'm joined by pelvic health physical therapist powerhouse and yoga-informed clinician, Dr. Ann Duch, better known as PT for Women. We're diving into the overlaps between concussion and pelvic health and vagus nerve and the silent suffering many of our patients experience. We also tackle inclusive healthcare language, social determinants of health, and how to show up for our LGBTQI+ patients with compassion and clarity. Whether you're a rehab professional, physician, or someone living with persistent symptoms, this episode will expand how you think about safety, healing, and trust. Let's get into it. Dr. Duch, welcome back to the Concussion Corner Podcast.
Thank you so much for having me.
I'm so happy to have you back, and let's get into some fun topics that, for me, I'm so blessed to feel like we have this platform to be able to talk to people like yourself and really spread this information of really what safety means in the clinic and for our patients. And, our mantra here at Concussion Corner is teach one, serve many. So I hope that by you coming on and having these conversations about pelvic health, sexual health, intimacy, that we can really make our clinicians more educated inside the clinics, and then therefore our patients can feel much more welcome as well. So I can't wait to kick this conversation off with you.
Let's do it.
All right, fantastic. So we've got symptom overlap between concussion and vagal dysfunction, right? So we know that there's dizziness, lightheadedness, digestive changes, sexual dysfunction, anxiety, emotional overwhelm across both of them, breathing pattern disorders, voice changes, and sensitivity to sound. So that's why here at Concussion Corner, we make sure that we're educating folks on that the most important thing you can do for a patient is validate their patient's symptom profile. And we do that by doing comprehensive targeted physical examinations. There's so much crossover with the cervical spine and whiplash injury and concussion. And then now we're actually having this conversation about vagal nerve dysfunction as well. So I would love for you to kind of bridge that gap for our concussion people that are often involved in orthopedics or neuro or sport in terms of rehab areas. And then if you can talk about how that crossover and that bridge happens between the patients that you're seeing with the vagus nerve dysfunction as well.
Yeah, thank you. I think there's so much crossover, not just in the vagus nerve, but in the pelvic health realm, right? We talked about before, we see so much gut dysfunction. We see so much sort of breathing dysfunction that then turns into presenting like an anxiety, a depression, a mental, we put it in the mental health corner, but it's really the physical symptoms driving a lot of the emotional well-being and vice versa. So I think, the vagus nerve is having a moment, and I love that. I think we really could relate the vagus nerve to every specialty in healthcare and in the physical therapy world, but especially in your world, in the concussion world, and my world in pelvic health, working on vagal toning. We say vagal toning, but working on the ability for the vagus nerve to regulate the system can be helpful for all of the specialties, I would say. I don't think I'm being too ridiculous in saying that.
I agree. And I think one of the key themes that we talk about, whether we're on the podcast, outside of the podcast, hanging out in person, it's safety in care for our patients. Oftentimes we see mismanagement of our patients, whether it's in the pelvic health world or it's in the concussion world. And again, on average, people don't trust healthcare providers before they come to see me, and they see 6 to 7 providers before they arrive to my doorstep. So with that being said, I want to make sure that we're talking about safety, inclusion, and, this word is being so just poo-pooed these days, with what's going on in this world, but they definitely have ramped up nervous systems and may not trust healthcare providers because, again, they've seen multiple before they come to see us, and then we get to safely care for them. So we talk about psychologically safe environments for care. And we want to make sure that we're using gender-inclusive terms that build trust and improves outcomes, particularly for the LGBTQIA community, which, again, 1 in 5 in this country identifies as LGBTQIA. And we've talked about social determinants of health, barriers to access, insurance, transportation, provider bias, medical trauma, underdiagnosis or misdiagnosis. So I'd love to kind of talk about some language that we should be aware of that I actually wasn't aware of up until I met Dr. Postas, who is a sport neurologist. And that's, assigned female at birth or assigned male at birth. And those are individuals who were designated female based on their anatomical or chromosomal characteristics at birth. And it may not align with their gender identity. And the same thing in reverse for assigned male at birth, PACES or AMAB. So sex and gender, sex being biological, gender being identity, expression, and lived experience. How are you educating your colleagues, your patients? How are you helping them feel safe inside your walls?
Yeah, that was a wonderful breakdown. Good job. I would say I've learned so much from my patients in this area because I've had to, try to stay up to speed. My whole thing is I want to keep learning for the person that's in front of me. What do they need from me? And I think sometimes where clinicians get it wrong is if you can be really transparent with your patients and say, hey, I'm learning about this. I want to make sure you feel safe and supported. If I say anything that doesn't align with kind of what we're doing here, can you please stop me? Can you let me know? I worked with a really amazing trans man who I learned more from him in a couple sessions. And, he said, I've never been with someone who's more gender affirming than you. I was so nervous that I was not saying the right thing or doing, and this was a couple years ago now. And he's still someone we go back and forth. He gives me lots of, if I have a question about something that I don't want it to be so clinical. I'm looking for the lived experience. He has made it very clear to me, I'm here, please reach out, contact me. And again, that's not something we do unless that's been extended to you. You're not just going to reach out to someone and ask for, hey, what can you teach me about this, that, or the other? I made it clear I'm seeking my own education and then where I might fall short. If I say something or do something that doesn't quite align with what we're doing, please, I would love for you to help me with that. That made that person feel more safe in my space than anything else I could have said or done. So hopefully that answers your question a bit there. But I think leaving a little bit of wiggle room for clinicians to know you might not, especially if you haven't been in this area, you might not get it right every time. You don't have to be perfect, but definitely having this relationship with a patient to be able to say like, oh, I'm really working on this. Please flag me if it's not working for you.
Fantastic. And it's one of the key things that we put out here at Concussion Corner. It's making our patients, our healthcare providers that we're educating with this podcast, which is a free open access. And then our academy side of things that we have 2 12-week courses with 30 hours of CE. At the end of the day, it's saying, you know what? I don't know, but let me take the time to find out. It's that simple. I don't know, but let me take the time to find out, as opposed to mismanaging them or underdiagnosing or not validating their patient experience. Like, yeah, they may have had hot flashes or they may have been heat intolerant taking a shower and they weren't able to subjectively express the what or how they were feeling. But it's our job to be able to clinically screen that and then make that referral out to potentially neuroendocrinology or, another provider.
And you're dead on with regards to letting someone, and I'm pointing over here because my patients sit on this side of the room, but being able to say, tell me your story. Tell me your story. Everything's important to me. Everything you want to share with me is important to me. Anything you think might not be relevant, I bet it is. Feel free to share your story. I will not interrupt, making them feel safe. It goes so far as to say, in the space that you're in, what is your lighting like? What is the background noise like? I've had plenty of people who saw other clinicians who were in a very loud space. And I love CrossFit gyms. CrossFit people don't come at me. I love CrossFit gyms, but there are some PTs that are setting up in CrossFit gyms seeking pelvic health. And if there's big, loud clanking going on and big, loud, fun music, I want fun music, but when I'm ready to have fun music and go to the club, if that is disruptive to the discussion that you're having, very sensitive discussion, that's not going to align for that person. They're not going to feel safe. They're not going to be able to say, I don't feel safe. Usually it'll be like, I don't know, it just wasn't for me. So when we talk about using inclusive language, having a space that is inviting for all, it all matters. It all matters.
Yeah, fantastic. And it's so great that you talked about, the environment. For me, I wasn't ready to return back to work because I couldn't tolerate my environmental changes. So I live with a persistent post-concussive symptoms, and part of that is a dysautonomia, so positional tachycardia, secondary to heat intolerance, dehydration. I don't have I'm not orthostatic, but we talk about that in brain injury and TBI world. Additionally, I couldn't go back to work where I was a junior partner because we transitioned to this big green new build, and we put in LED lights. And LED lights, if you talk to a PhD in lighting, when they came out too early, and they're actually very offensive to the eyes. So the Kelvin output is actually not consistent, and it's within variable between light bulbs. So before going into the nerdiness of all of that from from a physics and all the lighting 101 or 102 even, environment matters. So for me, when I'm even negotiating doing public speaking, I actually negotiate what kind of lighting there is, and I'll make sure I situate myself in between lighting, because I'm no longer shy about it. It's like, hey, I've got this vision handicap secondary to a brain injury. This is what I talk about and treat. So I need to make sure I have support, or I have a restroom after I do the 20-minute lecture, or 60-minute, whatever I'm doing.
Which is
so
amazing.
Important to connect to that.
It is. And sometimes people don't make that connection. Good job on you. An example I had a patient, my little plinth back here. She'd come in post cesarean birth, had a very traumatic birth, unexpected, epidural didn't work, et cetera, et cetera. I have her on my table. She came in later in the afternoon. I usually turn off my overhead lights, which are obnoxious fluorescent lights. Mm-hmm. I had them on for whatever reason. She lays down on the table, completely dysregulated starts crying. She doesn't know why. And then she makes this connection. It's the overhead light. That's the last thing she saw before she experienced this traumatic birth. This is how we learn, right? Absolutely. You experience a thing and you have to make the connection, and you go, okay, what can we do to fix this? And he made it clear. I bought 2 lamps. I said, when you come, we'll decide what works best for you. We'll go slow. You won't even get on the table, that sort of thing. So good on you for figuring that out and knowing that this is not going to work for me. And that's a big, huge life disruption, I'm sure.
Yeah. And I think also to connect to the lighting, it's that if you're in clinic and you're a doctor of anything, physical therapy, if you're an OT, speech pathology, neuropsych physician, lay down on the table, lay down on the plinth and look up. You don't have to be neurodivergent or have a brain injury or have MS to be offended, or, the ADHD, ADHD is very common now in terms of diagnoses that are happening. So light flicker is a real thing, and it is disturbing. In fact, one of my affiliations was with the burn unit at New York Presbyterian many moons ago, and they actually turned the lights off between 4 and 5 p.m. because what happens in a hospital, right? Everything neurologically offensive happens in a hospital between 8 and 4. We've got multiple meals happening. We've got PT, OT, all the rounding happening, and everyone's just overwhelmed and exhausted. So turn the lights off and just go, and you just see how your nervous system just settles in and relaxes. So I love that you're connecting to that too for your patients that may not be coming in with brain injuries, but also just need to connect to the feeling of safety. And, maybe they sat in traffic for 2 hours as well.
Yeah, for sure.
And now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show.
In concussion recovery, we talk a lot about dysautonomia and the sympathetic overdrive. How do you approach calming the nervous system from the body up? We find that clinicians and physicians that don't have training in concussion may just see the emotionality of the patient in front of them and aren't doing the comprehensive targeted physical examination. What's your approach in terms of calming that nervous system from the body up?
Yeah. So I think it's important. I think it can be important here to note, oftentimes, particularly in the PT world, we always frame things in the way that what makes your symptoms worse, right? What makes your symptoms worse? I want to focus on when folks are feeling good. I want you to pause and take a moment and notice your surroundings. Who are you with? Again, back to what is the lighting? What are the sounds? What does your body feel like when you're feeling good? Can we lean into that a moment? And I mean, really, what's your jaw doing? What does your chest feel like? What is your rib? We're getting that interoceptive feedback, if you will, so that we can start to notice when we are dysregulated, when we're experiencing whatever the dysautonomia symptoms you're having. Can we move closer to those, we say glimmers, closer to those spaces where things feel good? Can we change that first? Then we'll go through different types of breath work, because I think breath work can be a triggering thing for people, and people will say, well, just take a deep breath and relax, you'll be fine. That's not how that works. There are different types of breath work. There are different ways to breathe. Some will be very triggering for people. Some will feel very good. So I say there's a little bit of this investigative piece where we have to figure out what feels good in your body. Not what someone told you would feel good, but what feels good in your body. So figuring out what type of breath work might work for you. Can we let the jaw relax? I don't use the word relax very often because I think it's counterproductive for people. If I tell you to relax, Jess, what do you do immediately? You don't relax.
I don't relax. I'm a New Yorker. And we find that even with our Spanish speaking patients, when we're trying to learn different languages, we say cuile or relate. And then at the end of the day, it's like, these are New Yorkers. They don't know how to relax. So exactly. I'm telling them something that they don't actually have a connection to. So
it's like, that's not going to work for me. Yeah. So we come up with words. How can we quiet? How can we, what do we need? What can we do? Can we work on rib cage mobility? If we're working on rib cage mobility, we're working on diaphragmatic mobility. Can we use that diaphragm to help mobilize the vagus nerve? And that can help you dip into your parasympathetic nervous system. And I think it's important with folks. I do things called touch points too, where we actually put our hands on different parts of our body while we're breathing, and then take your hands away for a moment and just see what you feel. And these are subtle things. So if people are looking for a big, huge, like, oh, I did that thing and all of a sudden I feel like $1 million. It's no, subtle changes. What do you feel in your body? Can you feel a little buzz where your hands were? Can you feel the temperature of your fingertips change? We're talking about little nitty and gritty things that can help someone go, I do notice that. And then we can lean into that a little more and come away from the symptomatic side of things.
Fantastic. And, just connecting to what you just said here, just thinking about social determinants of health. And we just started kind of implementing that with some of our concussion patients. Again, we joke about it just to make it light, but again, we say mild traumatic brain injury there's nothing mild about it. And we actually cross over into your realm. It's like, you can't have a mild pregnancy. You're either pregnant or you're not pregnant. You either have a brain injury or you're not, or you do not. So just thinking about and the patient in front of you when you're telling them to relax, but also making sure, are we aware of what's going on behind the scenes? Are they about to lose their home because they can't work or take care of their children or use their saccadic eye movements if they're a thoracic surgeon, which is a patient I had one time that just could not practice because they could not converge for 11 hours and do this work, or they had some dysautonomia and they would become actual orthostatic during their times. Just fantastic, to kind of have folks connect to the trauma side of things, of where patients may be outside of your walls. But when you have someone that's kind of ramped up and elevated, what's some language that you find that will help them kind of be present in the moment when they're like, hey, I just sat through 2 hours of traffic. I was stuck on the subway. I was stuck in traffic. I really can't be here. What do you want me to do? Breathe or relax or touch my chest? Do you have any patients that come in kind of ramped up, and how do you unramp them so you can really do the work that you need to do? And this is way beyond therapeutic alliance, right?
Yeah. So, and this is going to sound silly, but I think lots of folks will understand. I relate it to the 100 Acre Woods characters. So there's Pooh Bear, there's Tigger, there's Eeyore, and there's Piglet, right? So Tigger is bouncing off the walls. Tigger probably needs to move a little bit before he can settle, right? You're not going to tell Tigger to just sit in the corner. Then you've got Eeyore, who, needs a little upregulating. Like Eeyore is always in this slow, we need to get Eeyore moving. All the breath work in the world is not going to get Eeyore to change his presentation until we get him moving. So I use those as an example. And Piglet and Pooh are the ultimate co-regulators. When they're with each other, they feel good. They're like best buds. This is where the therapeutic alliance, when someone comes into my space, if I can sense they're kind of Eeyore that day, I know we're probably going to move a little bit before we do anything else. Do they want to move usually? No. We are going to do some global movement. We might do a little dancey thing. We are going to shake our tail feathers. We're going to do some movement, accessible movement that's kind of disguised. Like, let's get moving a little bit before we work on the other things we're going to work on. Likewise, the Tigger that comes in that just sat in traffic or just got in a fight with her partner, and she comes through the door like DEFCON 10. She's like up here. we're not going to tell her to sit down and do breath work either. For her, we're settling first. I'm meeting her where she is. We're trying to come down a notch and then determining whether, hey, we might need a little movement before we settle down, or hey, do you need to take a second? So again, that goes back to that therapeutic alliance, reading what your patients need when they come through the door. And then we can get into some of the strategies. That person that came through the door at DEFCON 10, once she starts to settle, I say, hey, how do you feel in your body now? What are you noticing? Taking a moment, because she hasn't noticed her body all day. And that's the same person. Do you think intimacy is going to go really well for either of those people? Someone who's way down here or way up here? It's trying to find that somewhere in the middle where we can connect back into our bodies and then do the thing we either want to do, enjoy to do, etc. Yeah.
Fantastic. As you mentioned intimacy in the last 5 minutes of this podcast here, I want to connect to the episode that we just had prior to you with Dr. Jose Posas, a sport neurologist.
Which is amazing.
Thank you so much. I was so happy to have that conversation in our academy. And then it actually sparked the conversation of like, hey, Anne, you want to come on? Let's have this conversation. Yeah. So I'm so stoked that you're here. But how do you approach intimacy issues in your practice when pelvic pain or trauma is involved? And again, reconnecting to safety in the body. But at the end of the day, concussion patients don't have the subjective language to express the what and how they feel. And I'm going to say that twice because it's so important. And it's my shtick. I learned this from my own brain injury because we ask our patients all day long, how do you feel? How do you feel? Give me a VAS. How do you feel? And when you don't know how you feel, for me, that was so dysregulating because I did not know how I felt. And I had a doctorate in orthopedic residency training, in physical therapy when I had my brain injury. So when you don't have that subjective language to express the what and how you feel, how do we approach our concussion patients? How do you approach your pelvic health patients that, again, can't connect to their bodies, how they're feeling, where they're feeling? They don't know that they can't trust it. And they don't understand, hey, why is my heart rate super high when I go from supine to sitting to standing? And why can't I change positions with my partner or feel intimate or feel safe in my body? Therefore, how do I cross intimacy in those conversations? Take it away.
Yeah, I think, again, back to that feeling of safety. When I'm working with patients, we have a nice long conversation about all of I give them some ideas. Here's what some people say they feel, or, you start to give them some ideas. I'm never telling someone how they feel, but here's what I hear from other people. They feel like this, and give them actual words, and you'll see them go, that's it. That's the thing that I feel. When it comes to intimacy, sometimes two partners will have different types of libido at any given time. Some usually, and I'm generalizing, one partner might need a little bit more of a ramp up, lots more foreplay than the other person. So we're talking about how does the nervous system respond to these things? If I'm not feeling safe in my body and my partner comes in and is like ready to roll, what is my response is going to be shut down. So being able to communicate with your partners, and this is where we might do a little role play in my office where I'm like, hey, have you had a conversation? Do you feel comfortable having a conversation with your partner? Lots of times the answer is no, because they've never talked about these things before. This person's just been kind of gutting through the intimacy piece of their relationship until they've been met with some incredibly painful situation where it's just impossible. That pain didn't come from nowhere usually. So we're talking about how the nervous system and your response to pain are connected and kind of teasing that out a bit. Validating, of course you feel pain. I understand why you feel pain. This is not going to be with you forever. And making sure people feel like they can start to understand the sensations that they're having in their body, starting by validating those sensations. And that firsthand, and that as a clinician, that validation is so incredibly important. What is worse than a clinician saying to someone, that makes no sense, I've never heard that before, or that's the worst case of the thing I've ever heard, you're the worst person this is the worst I've ever seen it. It's like, is that helpful in any realm?
Yeah,
no.
We see that a lot with our orthopedic surgeons. That was the worst arthritis I've ever seen. Then, sir, you've not been doing this long enough.
The worst disc protrusion I've ever seen. It's like, okay, okay, yeah.
Yeah, and that goes into like words that harm, right? So we want to make sure that we're using words that heal, that we're looking at positive, And I used to joke, I'm like, hey, I don't like to go to therapy because I have a hypnotist that I've worked with for years, and he's fantastic. And we focus on what the future is going to look like, what we can accomplish, what is going to be in the future, and just setting the mind up, for success, as opposed to asking someone like, hey, what's your pain level? How dizzy do you feel? Well, I didn't know I felt dizzy, or I didn't know I had pain until this moment, or that's all I've been thinking about. And now I'm, becoming the hypochondriosis is a conversation that we see in traumatic brain injury and concussion. But at the end of the day is like, are we bringing that into our patients' lives by asking them over and over again, So
we are. What's your sitting tolerance? What's your sitting tolerance? What's your sitting tolerance? It's like, Well, I thought it was 10 minutes, but if I really pay attention, it's actually 4 minutes.
Right.
Yeah.
Well, as we wrap up here, when I asked you onto the podcast, you're like, well, Jess, what are we going to talk about? I was like, I promise you, Ann, we're going to have so much to talk about. Just give me a chance. But, if you could wave a magic wand and you can change how pelvic health therapists and neuro and ortho and sport clinicians work together, specifically, we're here in the concussion world, but at the end of the day, we have our CrossFit friends and colleagues that are opening up gyms and therapy offices in CrossFit areas. We have outpatient clinics that are hospital based, but in more of a gym setting. We have, all these different types of scenarios or where things exist, where therapy exists, I should say. What would that collaboration look like for you? And why is it so important to connect to that? The nervous system is one of the key things to help these persistent patients that may have been mismanaged by many healthcare providers coming before they came to see us. How would you like to see that collaboration work?
I would love to see that collaboration. I'd love us all to kind of be speaking the same language with our patients. I would love everyone to understand while we're in these kind of little silos, there is so much crossover, right? Your nervous system is going to affect your ortho is going to affect pelvic health. We cannot separate one from the other, which is why I think the work that you're doing with this interdisciplinary approach, we say it all the time, oh, we love to be interdisciplinary, but we're not really making it happen. And I think there's also some fear if I refer to this person, then I won't get that patient back. I have no concerns about that, by the way. If I'm doing my job and I'm feeling like I'm connecting with patients and I'm helping, I'll refer to the person I think would serve them best at this point, and we're going to have a collaboration. That's best case scenario. If I could wave that magic wand, I'd have us all speaking the same language and being in the room together more often.
Fantastic. And I think at the end of the day, we have that ability in the United States. We have listeners from all over the world. We're in over 60 countries, which is what a blessing for folks that are tuning in all over the world. But in the United States, we have direct access to our patients. So really educating communities, educating school districts, educating your OBGYN colleagues, primary care, just reaching across the aisle. I can say I'm so blessed to be able to work with like top 5, 10% of humans in my area in New York City. But I will tell you right now that I don't blindly refer. We use emotional intelligence and EQ, and I have a texting relationship with every single person that I refer to. So we want to make sure that we're not looking at it as my patient or your patient, but it's like, hey, here's how I as physio can treat, how you physician or OT or speech pathology, neuropsych, etc., can treat together. And here's how we can serve our patient together. And it has to be, at the end of the day, we're all in this 8-minute treatment realm that a lot of us are in hospital-based systems. But it's like, hey, what's your network look like? And how can you reach out to a Dr. Ann Collins Duch? And so I'm so proud to be able to have you in my network and have you on the podcast and have you serve your patients so well. Because again, at the end of the day, education is such a blessing. And there's so many ways that we can access it. And again, with over 100,000 followers on Instagram, you are really touching communities, touching lives, and changing people's outcomes. So just thank you for all that you do. And where can folks find you if they want to reach out to you?
Yep. So I'm mostly on Instagram, PT for Women. I'm diving into TikTok just a little bit and YouTube just a little bit. I'm trying to, but mostly on Instagram. You can find me at annduch.com. That's a website that gets to some of my virtual courses. I have What Happens in Vegas Doesn't Have to Stay in Vegas, a nervous system regulation course, and a couple other little courses there as well. So I'm so blessed to know you. I'm so psyched to be here. So thank you so very much.
Fantastic. Thank you. And we hope to have you on again. I know that there's going to be tons of questions that come through. So, all right, take care, everyone. If this episode resonated with you, share it, forward it to a colleague, a student, or a clinical director. Because creating safe, inclusive, and effective healthcare starts with awareness and continues with education. You can find Dr. Ann Collins Duch on Instagram at PT4Women, and you can check out her course, What Happens in Vegas Doesn't Have to Stay in Vegas, all about the vagus nerve. At Concussion Corner, our mission is simple: teach one, serve many, and we're so happy that you're here. Be sure to like, subscribe, and drop us a comment. Your voice helps us amplify the care our communities so deserve. We'll see you next time, and take care.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.